Hello and welcome back to Chapter 10 in Alternate Care Systems. We're going to pick up with reimbursement sources, and we're starting on page 373 in the text. So reimbursement ranges from simple to the complex in the long-term care setting because of the various sources of payment, type and level of the care provided by the facility, and whether a facility participates in Medicare and or Medicaid. A general overview of the various payment categories that are typically found in long-term care is provided on page 374 in Table 10-2. So look over that table. So let's start with Medicaid. On 375, Medicaid per diem based on overall facility cost. So Medicaid reimbursement for nursing facilities varies from state to state depending on the type of reimbursement methodology adopted by the state agency and the type of Medicaid coverage available in a given state. A common methodology is to calculate an overall facility per diem rate based on the basic facility cost reporting. These types of systems have no level of care distinction, and all residents are reimbursed at a flat daily rate based on a facility-specific cost data using a reimbursement formula developed by the state agency. All right, moving down to Medicare. Medicare Part A Skilled Nursing Facility Benefit. Medicare Part A coverage is limited in that a resident first must be eligible for Medicare Part A coverage and qualify with a 3-day hospital stay within the previous 30 days prior to admission to a Medicare certified bed and required the services of a skilled professional on a daily basis. If these criteria are met, the duration of the SNF coverage is limited to the need for the daily skilled care up to a maximum of 100 days per period of illness. Therefore, not every admission to a nursing facility will qualify for Part A benefits, and not every long-term care facility will choose to participate in the Medicare Part A program. Consequently, a resident chooses to utilize the Medicare SNF benefit following discharge from an acute care facility, he or she must select a facility provider that is certified to participate in the Medicare program unless the resident is covered under a Medicare risk contract with a health maintenance organization. Beginning in 1998, Medicare payments to SNFs changed from a cost-based reimbursement to a prospective payment system. Medicare Part A payment rates now utilize a case mix adjusted per diem rate. The per diem payments for each qualified admission are based on a resource utilization group or RUG. This case mix methodology is driven from the MDS. One of the 66 groups is assigned, and that payment is reimbursed to the facility for a specific period of time or until the next MDS is completed according to the defined schedule. The SNF PPS also assigns billing responsibility to the SNF for the entire package of care that residents receive during a stay. This concept is called consolidated billing. For example, physical therapy services are billed by the SNF, not by the physical therapy provider as part of the package of care. The physical therapy provider, in turn, receives payment from the SNF. The consolidated billing requirement has some exceptions. For example, Medicare does make separate payments for physicians' professional services, certain dialysis-related services, and other items. From a health information management perspective, a case mix reimbursement system such as the SNF PPS is affected greatly by documentation and accurate submission of the MDS data. Therefore, the quality and the accuracy of documentation has a direct relationship with the financial viability of a facility that is heavily dependent on Medicare reimbursement. Then we have a Medicaid per diem based on the level of care. So our first Medicaid per diem was on the overall facility cost. Now this one is going to be based on the level of care. So in some states, a Medicaid per diem or daily rate is established based on a level of care distinction for intermediate or skilled care on a case mix methodology developed by the state agency. In some states, the MDS is used as a resource document for calculating the level of care and extent of resources utilized for individual residents and for the facility as a whole. Depending on the state methodology, additional reimbursement may be recognized for intensity of services, such as may be the case with the care of AIDS, or for specific quality of care outcomes, such as would apply for the improvement in functional independence as a result of rehabilitation and restorative services. And then we have our RUGs, our Resource Utilization Groups, in Medicaid reimbursement. So, RUGs reimbursement methodology is a specific case mix payment system used in a growing number of states for long-term care Medicaid reimbursement. Using the MDS as the foundation for the data collection, states categorize reimbursement for individual residents based on their characteristics and service needs. From a general perspective, the methodology is based on the premise that if a resident has special or heavy care needs, the facility will be reimbursed at a higher rate than that for a resident who is more independent in care and requires less skilled or clinically complex services. Some states calculate the facility overall rate by averaging RUG scores from the scheduled MDS assessment submissions. All right, moving down to commercial insurance. Commercial insurance coverage for long-term care services is growing and is projected to increase with the aging of our population. There is great variability, however, in terms of the type and duration of services that are covered, because there's no standard definition of long-term care coverage as there is, to some degree, with major medical in relation to acute hospitalizations. In some instances, coverage mirrors the Medicare part of a SNF benefit and will reimburse the beneficiary for only a maximum of 100 days or for the period of time that daily skilled care is needed. In other instances, room and board expenses are reimbursed for a predetermined period of time regardless of the level of care. Often, the commercial insurance carrier will request copies of the resident medical record on a monthly basis to verify services rendered and to substantiate the level of care required by the beneficiary. Depending on the specific policy coverage, documentation of the level of care and scope or intensity of services is essential for assuring reimbursement from the third-party payer. And then we have our last two, managed care, and then our private payer, or private pay. So managed care, it's increasing over time. The predominant influence at this time is the Medicare SNF and the subacute sector of the long-term care industry. Managed care payers have entered into Medicare Risk Contract. It's a contract between an HMO and CMS to provide services to Medicare beneficiaries, under which the health plan receives a monthly payment for enrolled Medicare members, and therefore assumes responsibility for the SNF benefit for the enrollees. In addition, an increasing number of managed care payers are contracting with long-term care facilities for the care of non-Medicare enrollees who require the intensive post-acute rehabilitation and nursing services provided by SNF and the subacute units. To control cost of care, managed care payers are seeking affiliations with long-term care facilities that can provide the same or higher quality outcomes at a lesser cost per care episode than can the acute care setting. Consequently, managed care reimbursement is projected to increase in the long-term care setting for the low-cost, high-quality providers. All right, and we're going to go on over to private pay on page 378. Private pay in the long-term care setting denotes payment by the individual without any third-party payer. In some facilities, a global daily rate is billed to the resident monthly, including all meals, treatments, and supplies, with no additional line item charges other than medication supplied by the pharmacy. In other facilities, a daily base rate includes only room, board, and a nominal list of supplies and services, with additional services being charged for restorative services, incontinent care, specialized therapeutic activity programs, feeding assistance, and other services that are regarded as non-routine by the facility. The extent to which additional services are charged over and above routine services varies from provider to provider. All right, so we're going to move into our information management section. Management of information is an area of growing significance in the long-term care setting, not only from a reimbursement perspective, but also from a regulatory compliance and risk management perspective. The need is seen more dramatically in facilities participating in Medicare and Medicaid because of the information emphasis in the survey process and successful management of information-based reimbursement. All right, so moving over to page 379 under ICD. The current clinical modification of the International Classification of Diseases, which is ICD-10 here in the United States, these diagnosis codes must be used for submitting Medicaid, Medicare Part A, SNF, and Medicare Part B claims. However, their role is not significant in dictating the level of reimbursement the facility receives for an individual resident. Although inaccurate or incomplete codes may affect the timely processing of claims or increase the chances of a claim being isolated for medical review, reimbursement decisions are not solely linked to the ICD codes. Dropping down in that next paragraph, ICD codes also are a part of the diagnosis reporting information included in the minimum data set. It's a part of section 1. In this section, diagnoses are to be recorded in relation to current ADL status, cognitive status, mood and behavior status, medical treatments, nursing monitoring, or risk of death. A minimum amount of space is provided for recording actual ICD codes because checking the relevant box on a form enters the majority of the diagnosis information. If a diagnosis code provides more specific information relative to intensity of care or level of skilled services, a code should be entered in preference to the checkbox. For example, if a resident has insulin-dependent diabetes mellitus or uncontrolled diabetes, greater skilled supervision and monitoring is required than for a resident whose diabetes is diet-controlled. Consequently, an ICD code would provide greater information concerning the resident's level of care than would a simple description diabetes mellitus. Diagnoses and/or diagnosis codes, however, are not adequate to describe the level and intensity of care required by long-term care patients. All right, dropping down to CPT. CPT codes are used for billing Medicare Part B services for rehab, your PT, OT, and speech, and for the physician visits to residents in the nursing facility. For the rehab services, CPT codes indicate the type of therapy provided. For physician visits, the CPT codes describe the level of service provided, which thereby dictates the reimbursement for the visit performed. In a retrospective review of claims by the Medicare carrier, physician documentation must support that the level of service billed was actually performed and medically justified. Therefore, if a CPT code is used that correlates with a more intensive visit, documentation should support that more time was involved than for a routine physician visit. All right, so let's move on to data and information flow. All right, so we're going to drop down to the MDS data section at the bottom of 380. In the Medicare and/or Medicaid certified facility, data and information flow centers on the MDS, which is not only a vehicle for a clinical assessment process, but also is a mandated data set linked to regulatory compliance. Therefore, timeliness and accuracy of assessment information must be coordinated among the various disciplines and is a significant activity within the facility. From a data management perspective, the facility must ensure that systems are in place to monitor timeliness of the completion of the MDS and accuracy of the reported items. Further, a system must be in place to ensure that significant changes in conditions are properly identified, assessed, and communicated to the appropriate individuals, as this represents an area of federal regulatory compliance. After the MDS is completed, information is used to establish which care areas are triggered, either through an automated RAI process or through manual review of the MDS trigger legend. Therefore, coordination of completion among the various disciplines is an ongoing process within the nursing facility. In addition, information regarding changes in resident condition must be monitored continually to determine if specific criteria are met that indicate a possible need for new comprehensive assessment. And so if you look over on page 381, in that text there, these assessments have to occur in case there is either a decline in the patient's status or if the patient improves. And so federal regulations define a significant change as a major change in the resident's status with the following conditions. And so you see there's three on this page, and they have a lot of different information in them. So that's what's going to be your criteria for determining whether that patient has a significant change. So read through those. For one of the things, it's any decline in ADL functioning for which a resident is newly coded as 3, 4, or 8. Extensive assistance, total dependency, or activity did not occur. So any changes in what the patient is able to do for themselves, any changes in their decision making, any changes in their incontinence patterns, or if they're sad or anxious, or they start seeing, unplanned weight loss. So some of those things will show decrease or a decline in your patient. All right, so dropping down to level of care evaluation. Reasons differ for residents who require permanent care in a long-term care facility. Some require a higher level of skilled intervention daily, whereas others may need less intensive care. Depending on their diagnoses and overall condition, residents may decline rapidly and require more intensive services. For this reasons, facility develop methods for defining individual resident acuity and care needs, and will attempt to place residents with similar needs in the same physical area or unit of the facility. As residents' conditions change, their care needs change. The relocation to more appropriate areas within the facility could be required. Generally, the type of information that would be utilized for this assessment would depend on the care issues outlined in Figure 10.2. So we have enteral feedings, wound care, ostomy care, acute unstable condition requiring skilled monitoring, and then your dependence on staff, if they have to be fed or need just supervised feedings, or the number of staff required for transfer and mobility, or the number and extent of staff assistance required for dressing and personal hygiene. All right, we have our utilization of supplies and services. Regardless of the resident's pay source, information regarding utilization of central supply items and special services must be maintained for cost accounting purposes. Some facilities manage supply information with the use of scanners, a system in which charge information is captured automatically at the point of use. In other instances, supply utilization is managed totally by a manual tracking system. Improper management of this key area of the facility operations can result in a tremendous amounts of loss of revenue to the long-term care facility. All right, dropping down to external data reporting on 383. Facilities participating in the Medicare and/or Medicaid programs are required to submit MDS data to the state agency. In compliance with the individual state requirements, facilities submit individual resident MDS data to the state agency electronically. The state and federal agencies both utilize the individual resident and aggregate facility data to monitor quality by individual provider and to evaluate trends in care throughout various regions of the country. The submitted MDS data are utilized by state surveyors to identify focus areas to review when performing the facility standard survey. In some states, MDS data are also used to establish the facility Medicaid reimbursement. All right, and then we have our electronic information systems. With the advent of mandated electronic submission of the MDS data, the long-term care industry has seen a growing number of vendors specializing in long-term care software. The extent to which facilities are able to totally computerize clinical and financial data, however, is still dependent on the financial constraints of the average long-term care provider. As a result, there are wide ranges of utilization of electronic information systems within the industry, from standalone systems used strictly for processing MDS data to systems that integrate all financial and clinical information successfully within the system. Some of the more common elements of software applications are as follows. So you may have physician orders, your medications, or different treatment records. You can have your financial information, which will include census, payroll, billing, cost reporting data. Then you have your electronic MDS system with your care area triggering system and your care plans. And you can have integration of care plan with the nurse aid assignments. electronic interdisciplinary progress notes, electronic assessment templates, and then electronic tracking of incidents and accidents, infections, and other significant events. Moving over to 384, CMS provides free software called Raven for entering and transmitting MDS assessment data. The Raven software imports and exports data in the standard MDS record format, maintains facility, resident, and employee information, enforces data integrity via rigorous edit checks, and provides comprehensive online help. Facilities also may choose to submit MDS data using software purchased commercially through a vendor, provided that the software meets the CMS standards. All right, moving down to data sets at the bottom of 384. MDS has become the universal data set for long-term care industry. MDS 3.0 took effect in October 1 of 2010, and it replaced MDS 2.0. The initial goal of CMS in establishing MDS was to combine the benefits of a standardized clinical assessment tool with a universal data set for monitoring key information within the long-term care industry. Now that the MDS also supplies information important to reimbursement, CMS is concerned with the potential for fraudulent reporting of MDS data. The MDS form includes a formal statement certifying accuracy of information for all the MDS sections. Each staff member completing a portion of the MDS document must certify the accuracy of that portion by signing an attestation statement, which includes verbiage warning of criminal, civil, and/or administrative penalties for submitting false information. For the PPS Medicare covered admission, the MDS is required to be completed on a 5-day, 14-day, 30-day, 60-day, and 90-day schedule to acquire Medicare payment. Deviation from this schedule while the resident is covered under Medicare results in the default or lowest payment rate. All right, we're going to move over to quality improvement over on page 387. Researchers at the University of Wisconsin developed the first MDS-derived quality indicators. These indicators can be utilized to monitor quality, both in process and outcome, through the automated use of MDS data. Figure 10.5 provides examples of quality indicators based on MDS data. From a facility's perspective, many of these indicators also correlate directly with compliance monitoring for key federal quality of care and quality of life regulations, as noted in Figure 10.5. As part of the CMS Nursing Home Quality Initiative, CMS hosts a Nursing Home Compare website that provides information about nursing homes in the form of quality measures. This information is posted for nursing homes in all the states with the intent of assisting potential residents and their families in making an informed selection if they have to consider a nursing home placement. Ever since 2008, the Nursing Home Compare website, which is www.medicare.gov/nhccompare/home.asp, has included a 5-star quality rating system for all Medicare or Medicaid certified nursing homes. CMS intends this system to be a tool to assist consumer decision-making. The rating is updated monthly with any new information. The 5-star rating includes 3 categories of performance measures: health inspections, staffing, and quality measures. The 3 measures determine a facility's overall composite rating. A rating of 1 to 5 stars in each of the 3 categories, as well as a composite star rating, is assigned. And so if you look at 388 and 389, you have the MDS-derived quality indicators in Figure 10-5. All right, we're going to move over to utilization management on 390. In the long-term care setting, utilization management applies to the Medicaid, Medicare Part A, and managed care residents who may be in a SNF or subacute unit of a facility. Each state has individual requirements for qualifying for Medicaid nursing home payments, and the manner in which the process is monitored varies state from state. In some instances, qualification is monitored through the MDS data in conjunction with the additional state-specific information submission. In other instances, the state agency adopts a separate review process to determine initial and continuing Medicaid eligibility. For the Medicare Part A SNF benefit, utilization must be monitored to ensure that the condition of the resident meets ongoing criteria for daily skilled care. In addition, the facility must be aware of SNF days that the resident may have and use before being admitted to the SNF unit to ensure that the stay does not exceed the maximum benefit of 100 days per period of illness. Dropping down to that last paragraph. Utilization management for managed care residents, typically those in a SNF or a subacute bed, is a dynamic process that requires frequent monitoring by the facility case manager to ensure that care needs and progress are communicated to the managed care case manager on an ongoing basis. The facility must be in a position to communicate changes in resident status and the discharge plans to the managed care payer. All right, moving over to risk management and legal issues, and then we're going to wrap it up with our role of the health information manager. Risk management and legal issues in the long-term care setting are similar to those in other healthcare settings. Proper tracking and documentation of incidents or potentially compensable events is just as important in the long-term care facility as in other settings. Clinical issues that present risk to the facility include pressure ulcers, falls, fractures, medication errors, infections, and dehydration. Long-term care facilities can use quality management techniques and monitor quality indicators to improve the quality of care and lower the level of legal risk. All right, and to wrap it up with the role of the HIM manager. Credentialed health information managers, RHITs and RHIAs, are not required in the federal long-term care regulations, but may be required on either a part-time or a consulting basis in some of the state long-term care licensure laws. The trend toward automation and use of health information in long-term care reimbursement has increased the importance of the credentialed health information manager in the long-term care setting. As a result, independent facilities and long-term care management corporations are expanding their use of full-time registered health information technicians and registered health information administrators. RHITs and RHIAs have received formal education in health information management that can equip them for several roles in long-term care. Many long-term care facilities employ credentialed health information managers as full-time directors of health information services. Another role is that of a health information management consultant who may focus on a specific area of information management such as auditing documentation. Whatever the role, the health information manager must understand, apply, and stay abreast of pertinent regulations and follow professional best practices. So let's talk about the role of auditing. So one role of the health information manager in a long-term care facility is to design and implement auditing systems. Of significance to the long-term care facility is the content, completion, accuracy, and timeliness of medical record documentation. Documentation affects the quality of care provided. Assessment and ongoing care planning are determined in part by what is written in the medical record. Documentation also is a necessary factor in outcomes for reimbursement systems, survey compliance, and in the event of legal action. The medical record serves as a tool in QI studies and is used in facility planning. Health information managers and other trained staff can be a valuable asset to the long-term care organization by conducting routine documentation audits against established criteria. Results of such audits can be used to help ensure quality care, survey readiness, and proper reimbursement. In addition, audit outcomes can be utilized as measures in training healthcare staff and for system evaluation and improvement. Audits can be quantitative or qualitative in nature. Quantitative audits include review of whether medical record forms are complete, timely, and signed by the authors of the forms. Qualitative audits generally require more training because they entail a more in-depth look at the actual content of the medical record. Utilizing a defined set of criteria for auditing or a review form promotes consistency and objectivity. Audit forms can be created by giving consideration to regulatory requirements and what the facility defines as useful information to collect. Typical items in a long-term care audit form include the following: the timeliness of the MDS assessment, physician orders signed, advance directives addressed, allergies identified, assessments completed by each discipline, medication orders consistent with medication records, physician progress notes coinciding with required visit schedule, and laboratory results in the record for all lab tests ordered. All right, let's move over to an external consultant versus a full-time employee on 393. As a consultant, the HIM professional conducts periodic visits ranging, for example, from monthly to quarterly to monitor documentation trends within the facility, particularly as this relates to potential regulatory compliance concerns. The HIM professional brings expertise in terms of resident confidentiality and release of confidential information, and also serves as an ongoing resource for development of forms and documentation systems and procedures that facilitate compliance and promote proper reimbursement. With an increase in automation, the HIM consultant is also a useful resource in selecting electronic information systems that are suited to the needs of the facility, while also meeting specific state and federal requirements pertaining to automation of resident information. From that perspective, the HIM professional offers expertise in terms of evaluating the adequacy of existing traditional paper systems and provides valuable insight as to the necessary steps for streamlining and preparing manual systems for the gradual transition to an electronic resident record. Over to 394 for our last section. The expertise of the HIM professional offers numerous opportunities in the long-term care environment, particularly as information management becomes more crucial to monitoring regulatory compliance and ensuring proper reimbursement from Medicare, Medicaid, and managed care payers. Skills in streamlining workflow, management of information for QI initiatives, and data collection and analysis for critical pathways are growing areas in the SNF and the subacute care settings in which the HIM professional can offer tremendous value. So again, as always with these lectures, ensure that you read the entire chapter. You can read through that PowerPoint as well. Be sure to complete your quick check and your test yourself. And good luck and happy reading and happy studying.